Hi, my name is Chen Dong from Alaris. I'm very happy to present our poster titled Non-Invasive Metabolite-Based Urine Signature Detects Over-Immunosuppression in Renal Transplant Recipients. This is work done by Alaris in collaboration with Dr. Dirk Coopers at University of Leuven in Belgium. Over-immunosuppression is a long-standing challenge in treating transplant recipients, and infection is the second leading cause of death with a functioning graft in renal transplant recipients, or RTRs, within the first year post-transplant. One common infection is BK virus infection, which causes polymovirus-associated nephropathy, or PVAN. PVAN occurs in up to 10% of RTRs and can lead to graft dysfunction or loss. At Alaris, we uniquely combine metabolomics and machine learning to identify biomarkers associated with disease status. Altered metabolism has been linked to changes in kidney function and transplant tolerance, and our cerebral platform can detect and quantify hundreds of metabolites from patients' urine samples. Building upon a pilot study where we identified a highly accurate metabolic signature of biopsy-confirmed PVAN, we expanded the study to a larger cohort comprising 115 RTRs with longitudinal samples over 2 years post-transplant, including 15 patients experiencing PVAN at 90 days and 38 experiencing PVAN at greater than 90 days. With a total of 53 PVAN longitudinal samples, to the best of our knowledge, this is one of the largest PVAN studies. From these patients' urine samples, we extracted metabolites, analyzed them using HSQC and NMR spectroscopy, and identified them using known metabolite libraries. We then developed machine learning models to differentiate patients with PVAN from those with stable graft or under immunosuppression, predicted patient status from metabolic scores developed by Alaris were compared to pathology results from gold standard biopsy diagnosis. In our analysis, and as cooperated in transplant literature, we found that the patient's status after the first 90 days post-transplant was critical. In particular, Kaplan-Meier analysis showed that patients appear stable at 90 days, but later developing PVAN had a lower probability of survival and of retaining a stable graft than those with stable grafts or even with PVAN or rejection at 90 days. This suggests that identifying PVAN early on and identifying patients at risk of later PVAN has the potential to improve patient care and increase survival after kidney transplant. Similarly, we found that metabolite levels at 90 days were significantly different compared to later time points, even within the patient cohorts shown in the top 2 heat maps, suggesting that metabolism is altered and detectable in patients early on post-transplant. Importantly, we also found metabolic differences comparing patients with PVAN versus those with rejection or stable graft at 90 days, as shown in the lower heat maps. Using these differential metabolites, we generated cross-validated machine learning models, which were then used to develop a MyAlaris KTdx score to differentiate patients with PVAN at 90 days from other patient groups, as shown in the waterfall plots. Notably, our score differentiates patients with PVAN from those with rejection had 100% accuracy. This is exciting, as clinical practice showed that under the microscope, PVAN and the T-cell-mediated rejection can look similar using the Neum-Banff criteria. While these results suggest that these groups are clearly differentiated using our metabolic scoring method. We were also able to differentiate PVAN from stable graft at 90 days. We next applied our model to patients at risk for later PVAN, those who appear stable at 90 days but develop PVAN within the next 2 years. We found that we could differentiate at-risk patients from both stable patients and those with early PVAN. Then, by stacking these models, we created an ensemble model with high accuracy to identify patients in our foregroup: those with PVAN, patients with under immunosuppression, patients with stable grafts, and patients who appeared stable but were at high risk of later PVAN. To illustrate the potential clinical use of this product, clinical information and biopsy status are shown for 1 example patients from each group. Although clinical measurements such as GFR and serum creatinine vary greatly and did not reliably classify these patients, the myOlaris KTdx score prediction perfectly aligned with biopsy diagnosis for each of these patients, as well as for most of patients in each cohort. We are also encouraged that our scoring model were able to detect PVEN in patients who develop PVEN at greater than 90 days compared to stable patients. This is exciting to note that patients who recovered from PVEN, as confirmed via biopsy, also classified as stable using in this model. We are working to further optimize the model as it suggests the myOlaris KTdx score could be used to monitor for longitudinal PVEN recovery. In conclusion, by applying the Olaris cerebral platform to urine samples from RTRs, we identify differential metabolite resonances in patients experiencing PVEN versus those with stable grafts or under immunosuppression. The myOlaris KTdx score could potentially offer a non-invasive, urine-based analysis to diagnose PVEN, differentiate PVEN from rejection, and identify RTRs with stable graft function. This would avoid invasive, potentially dangerous, and costly biopsies while still providing clinicians with confidence that the immunosuppressant dose is correct for a given patient, or to confidently alter the dose accordingly to avoid graft rejection or infection. Further direction including expanding our study to a larger cohort with a more diverse patient population, as well as seeking to identify additional infections and complication of over-immunosuppression. Thank you.